So we're gonna talk about all the reasons that cause steatorrhea. Steatorrhea means lack of absorption of oils and fats in the gastrointestinal tract, leading to oily stools. Oily stools also smell really bad and they have a different odor and they swim when on the surface of the water, do not sink. So this is the description of and it's really liquidy and diarrhea in nature, the stool, because it exerts an osmotic effect and pulls water out from the GI tract as it moves down as well. So the number one reason is pancreatic insufficiency. What can cause pancreatic insufficiency? Number one, we have chronic pancreatitis. Repeated episodes of acute pancreatitis result in destruction of the exocrine glands in the pancreas, so they don't and no longer produce pancreatic enzymes, so there is no digestion. So that results in steatorrhea because there is no digestion, there is no absorption of fat, just passes in the stool. Chronic pancreatitis, one of the high yield reasons is alcohol abuse. How does alcohol abuse cause chronic pancreatitis? Alcohol abuse causes transient and episodic constriction of the ampulla of Vater that can precipitate episodes of acute pancreatitis. Cystic fibrosis. It causes thick secretions that clog the pancreas when the pancreas tries to secrete, and this results in progressive destruction of the pancreas, resulting in chronic pancreatic insufficiency. So this is the mechanism behind cystic fibrosis causing pancreatic insufficiency. And now we have pancreatic cancer here as well. So pancreatic cancer that occurs at the head of the pancreas causes obstruction of the pancreatic ducts and the bile ducts both. So this results in a lack of secretion of bile and pancreatic enzymes into the GI tract, and this causes lack of digestion, and that lack of digestion then presents as steatorrhea. So we're gonna cover small bowel Crohn disease is also a reason for steatorrhea because the site of involvement is usually the small bowel, and the inflammation is transmural or full thickness, that results in disruption of the absorptive capability of the small bowel, resulting in steatorrhea. Bacterial overgrowth that can also lead to steatorrhea. How? Bacterial overgrowth in the small bowel causes deconjugation of the bile salts. So the bile salts, when released from the liver, they contain conjugated bilirubin, and bacterial overgrowth results in deconjugation of the bilirubin. So the bile salts are rendered ineffective, and since their function is to aid in the absorption of fat, so that cannot happen anymore. So this results in steatorrhea. So basically, bile salts help in emulsification, which is a process where the fat droplets are divided and broken down in order to increase their surface area so that the pancreatic enzymes, the lipases, can act better and cause the digestion. So the next reason is primary biliary cirrhosis. Primary biliary cirrhosis is basically the intrahepatic destruction, autoimmune destruction of the biliary ducts. It usually seen in women. It's an autoimmune phenomena, and the antibody associated with PBC is anti-mitochondrial antibodies. This is what you need to remember. So once there is destruction of the intrahepatic bile ducts, bile salts are no longer released, and that is what causes steatorrhea due to improper absorption. Primary sclerosing cholangitis. So this is also inflammatory condition of the common bile duct where there is calcification of the common bile duct in an onion skinning pattern. So uh, this also results in lack of bile salt release since the common bile duct is involved, and so this results in steatorrhea as well. Surgical resection of ileum, obviously ileum is involved in the absorption. So if ileum is taken out, the fats are no longer absorbed, and that results in steatorrhea. So impaired intestinal epithelium surface, what causes this? Celiac disease. It causes atrophy of the villi, so the villi cannot properly absorb anything, so that results in steatorrhea as well. Giardiasis, uh, it is caused by Giardia lambia, that causes temporary or transient dysfunction of the epithelium, intestinal epithelium, resulting in steatorrhea. So AIDS enteropathy is also one of the reasons, but GRDS and celiac, these are the high yield ones. So other we have Whipple disease, which is caused by Trophiderma whipple, which is a bacillus, and as it infiltrates the intestinal epithelium, it causes dysfunction, and that results in improper absorption. Zollinger-Ellison syndrome is basically uh, it is basically a syndrome, or you can call it uh, so basically it is a cancer. It is caused by gastronoma. Gastronoma is excessive proliferation of the endocrine cells present in the uh, stomach that produce gastrin. So gastronoma causes excessive release of gastrin, which stimulates excessive release of hydrochloric acid from the parietal or oxyntic cells of the stomach lining. So this results in excessive amounts of secretion of stomach acid regardless of the stimulus, and this continued excessive amounts of acid also reaches the duodenum, where usually what happens is secretin is released that causes down regulation of gastrin and reduces the production of stomach acid. But in case of Zollinger-Ellison syndrome, there is no down regulation, so acid continuously pours down into the duodenum, and what happens as a result of that is the duodenal lining is damaged, and the pancreatic enzymes that require alkaline pH to function do not receive that alkaline pH. Instead, they are deactivated and they are denatured by excessively low pH, that is excessively acidic pH from the stomach. So this in turn results in reduced efficiency of digestion and absorption due to disruption of the pH balance in the stomach, in the lower GI tract, which includes duodenum and everything that comes after it. So this is what causes steatorrhea. Main reason is excessive acidic environment in the duodenum, resulting in enzyme deactivation and epithelial barrier dysfunction. So giardiasis. Giardia is basically a protozoa that invades the gastrointestinal tract due to fecal fecally contaminated water or food sources. Usually this is the main way of spread. How can you, what would be the main demographic? A traveler that is traveling and drank some water from the water stream that was not purified, or people living in closed spaces where food and water is shared. So these are the demographics where you would see giardiasis. So what happens when the protozoa enters the GI system? It does not invade deep inside the tissue. It just sticks to the epithelial or mucosal lining, and it causes damage to the villi. The damage to the villi also results in loss of absorptive surface area. It also destroys the brush border enzymes as well. So all in all, it causes malabsorption. What happens when there is malabsorption? You're gonna get steatorrhea, and usually the symptoms are just loose, oily, non-bloody stools. And since there is malabsorption, you would also get the hallmark symptom of blotting and flatulence, since the unabsorbed nutrients are acted upon by the bacteria, in the present in the gastrointestinal tract, and it produces gas which causes bloating and flatulence. And due to chronic nature of the disease, if you have chronic GRDSs, you're gonna experience weight loss, and in children it represents as decreased growth velocity. So the demographics mainly that you need to remember: a traveler, a daycare, nursing homes where the water, food intake is shared, and any states of immunodeficiency such as an HIV patient or a cystic fibrosis patient or IgA deficiency patient. So the pathophys is really easy. It attaches to the lining, causes destruction of the brush border enzymes and blunting of the villi. The blunting of the villi is a hallmark finding, and you need to remember villus atrophy would be seen in celiac disease, villus blunting would be seen in GRDSs. And one more high yield thing that I wanted you guys to know is that they're also gonna give you a case of lactose intolerance and ask you what is gonna be seen at the histopath. And there would be an option of villus blunting and or villus atrophy in the options. But the thing is, when it comes to lactose intolerance, the appearance of the villi would be normal. So there is no abnormal finding on histopath when it comes to lactose intolerance. So keep that in mind. The villus blunting is seen in giardiasis, villus atrophy is seen in celiac disease, but when it comes to lactose intolerance, there is no such finding. The histopath is completely normal. So basically, it's just diagnosed symptomatically or with the hydrogen breath test. So other than that, when it comes to GRDSs, the demographic is kept in mind, the symptom onset is kept in mind, and then you do a stool antigen or PCR testing and it is confirmed. So now let's just move on to the treatment. So the treatment is basically, usually you would have heard a brand name Flagyl that contains metronidazole. That this is clinically the most widely used metronidazole that used to treat GRDSs. But when it comes to the first line treatment, it is actually tinidazole or nitazoxamide. When it comes to pregnancy, you're gonna opt for paromomycin. So one more thing that you need to know is, without treatment, it is also gonna self-resolve within a month. But treatment is recommended whether the patient is symptomatic or asymptomatic, regardless, so that we can prevent the spread of the disease. So here we also move on to another high yield question, that is epithelial ovarian carcinoma. So this disease has a really variable presentation, and what you need to do is that if you get an old woman that is post-menopausal and that woman develops alarm features such as weight loss and sudden onset of constipation, you're gonna rule out everything else. Like for example, if the patient has constipation that is sudden in onset, has occult blood that is positive, and has been experiencing weight loss, you're gonna order a colonoscopy. And if the colonoscopy is clear, you're gonna order a pelvic ultrasound in order to visualize the ovaries. So basically, if a patient, older patient, a woman is having acute onset of symptoms such as constipation, occult bleeding, weight loss, and you rule the GI symptoms out with the colonoscopy, you're gonna follow it with a pelvic ultrasound in order to visualize the ovaries, the uterus, in order to make sure that it is not epithelial ovarian carcinomas. Why do we do this? Because I'm not reading this specifically to you, because the epithelial ovarian carcinoma has no specific presentation that you need, that I could give you to remember. So basically the presentation is really vague. The only thing in this that can give you a really clear distinction about this is adnexal mass, weight loss, and that is it, and a postmenopausal status. So this is gonna prompt you to order a pelvic ultrasound, and that is how you can further visualize that the patient has a certain disease. So basically, If a patient has, what I mean to say is, if a patient has really vague symptoms, is postmenopausal in status, has weight loss, hematochezia, acute onset of constipation, and you do a colonoscopy that is clear, the next best step should be to visualize the ovaries, the uterus with a pelvic ultrasound. That is the main takeaway of this discussion. Ovarian cancer should be considered in a postmenopausal woman with alarm symptoms. Once you've ruled out the GI causes, you move on to the ovarian causes. So let's just give it a read as well. Onset of constipation, particularly when accompanied by early satiety or pain, unrelated to bowel movements, alarm features such as weight loss, hematochezia, and a family history of malignancy or IBD. Colon cancer should be ruled out. As I told you guys, hematochezia prompts us to rule out colon cancer or any other reasons such as hemorrhoids or fissures. Fissures can be ruled out visually. Hemorrhoids can be ruled by proctoscopy, but then you need to perform a colonoscopy in order to make sure that nothing else is wrong. After that, you do a pelvic ultrasound in a postmenopausal woman. So I just wanted to give you a breakdown of how things and investigations move forward. Examination often demonstrates abdominal distension on an adnexal mass but may remain normal until late in disease course. That is why I said the presentation is really vague. So a pelvic examination and imaging should be considered in an older woman with new onset abdominal symptoms. That is the takeaway point here. So in this question, the patient had constipation and there were no anal fissures and the diet was appropriate. So there was an option termed as biofeedback therapy and pelvic floor muscle exercise. So this can also be an option when it comes to functional constipation in elderly people. Since elderly people have a poor coordination of the reflex that causes bowel movement, so it can treat dysenergic defecation, which is a cause of functional constipation, and fiber supplementation is also a treatment for constipation. But you need to make sure that you rule out everything else with a colonoscopy and a pelvic ultrasound, because the patient not only in this case had constipation, the patient had occult bleeding and the patient had weight loss. So these are not signs of just constipation. You need to be wary about another more dangerous diagnosis in place and rule out everything else before you fall back to treatment of functional constipation. Fecal impaction. So this is also a really weird topic. Fecal impaction, as the name suggests, chronic constipation leading to fecal impaction that prevents the flow of bowel movements out of the body. So how is the presentation gonna be like? That is the weird part. The patient is gonna present with complaints of fecal incontinence. So what is this irony going on in here, that it says fecal impaction, but the patient says that my stool is leaking out. I have fecal incontinence. So the reason is that fecal impaction initially causes a blockage and the stool proximal to the blockage then keeps piling up until it starts leaking along the sides of the impacted solid stool. So the complaint starts with usually the patients are elderly patients who have diseases such as Alzheimer's, dementia, and are immobile. And the attendings complain that the caretakers complain that the patient is having fecal incontinence, but in reality, the patient has an impacted stool. So fecal impaction is common in older patients with impaired mobility. Why does impaired mobility result in fecal impaction? Because impaired mobility is associated with chronic constipation. Inadequate fluid or dietary fiber intake is also associated with chronic constipation. Basically, chronic constipation, and since the patient have impaired mobility or have dementia, or that results in decreased sensation of the reflex that causes rectal vault emptying. Obstruction of the fecal flow in the rectum causes backup of stool proximally. Passage of liquid stool around the impaction leads to fecal incontinence. So basically the problem is fecal impaction. How are you going to identify that the problem is fecal impaction leading to
fecal incontinence and not just fecal incontinence by looking at the demographic of the patient. That is really important. The patient would be really old, immobile, and may or might not have spinal cord injury or dementia. And the caretakers are going to complain that the patient is having fecal incontinence and just gets the bed dirty again and again. So then you ponder upon and then you figure out the demographic gives you a really great idea about the diagnosis. The diagnosis of fecal infection is typically apparent on digital rectal examination, although infection in proximal rectum may be apparent only on abdominal x-ray. So you do a DRE and then you are able to palpate the hard stool stuck, and that is what confirms the diagnosis that the incontinence is basically due to impaction. Initial management includes you're gonna manually disinfect the stool, break up, give enema, and dislodge the hard stool, and the patient is gonna be all well. Following acute treatment, a bowel regimen including laxatives. So after the fecal infection is treated, you're gonna make sure that the patient does not get constipation again, and you're gonna give the patient laxatives such as polyethylene glycol, lactulose, and dietary alterations. You're going to increase fiber intake, ask the patient to be more mobile. So the high yield presentation or high yield example would be a 70-year-old Alzheimer's patient complains of fecal incontinence by caretakers. What is the next best step? So since the demographic fits really well into someone who is supposed to have chronic constipation, since it's a patient with dementia really old, so you're gonna do a digital rectal examination that's gonna make everything clear whether there is impacted stool or not. So this is a x-ray that shows severe constipation. So how are you gonna uh, uh, identify severe constipation on an x-ray? Just by seeing the x-ray you are not going to be able to do that. As I've mentioned it many times before, x-ray is just a modality that helps you link the clinical presentation with the diagnosis. You cannot make a diagnosis alone just by seeing the x-ray. So if you get a patient who has not passed stool for 2 to 3 days, complains of bloating, abdominal pain, and bowel sounds are really sluggish in that patient, and that patient has a old age, and that patient is supposedly immobile, that is the clinical presentation that is gonna prompt you to look for reasons of constipation, either be it bowel obstruction or fecal impaction or anything like that. Once you get a clinical picture, you order abdominal x-ray, and if the x-ray shows something like this, so it's really becomes easy if you have an anchor image of the x-ray in your mind. So this is the anchor image which shows that bowel gas is present between in the large intestine. The bowel gas looks like the bowel gas is hyperluminant, basically just black, and the tissue or the stool would be dense and thus it would appear whitish. So in this case you can see that within the bowel, within the large intestine, you can see whitish masses, not just whitish masses with hyperluminancy between them. Let me just focus it more, so it's gonna be more easy to visualize as you guys can see it. So just follow the cursor. As you guys can see that in this case it's just normal bowel gas. There is no texture within the bowel. But in this case you can see the white mass that represents that there's a density within the bowel, plus you can see air trapped. This is hyperluminancy texture within the white masses. Similarly you can see here as well, you have a grayish mass with black gas within it. So this is basically stool that has been trapped within the bowel, as you can see. And with combined with the clinical picture, you can make a diagnosis of constipation. So it's not just about the x-ray, you have to combine other stuff as well, and that is what confirms.
So we're gonna do the secondary common causes of constipation now. So Let's move on to the most common causes. You've heard that elderly people have constipation. Why? Because of reduced mobilization. Reduced mobilization results in reduced mobilization just means the patient is not walking, running, or is not physically that active. What happens is that the gut slows down since the body movement is overall reduced. That results in constipation. Low fiber diet is another one. Dehydration is another one. Dehydration since in dehydration since constipation, one of the big reasons for constipation is dehydration of the stool. So if you're dehydrated to begin with, so that also contributes to this. Functional, what does functional constipation mean? Functional constipation means that there is no pathophysiology behind the disease, and functionally there is no issue such as that of the GI tract or dietary intake. It's just functional. There is no issue, but the patient is still having constipation. So the two reasons for that is IBS, where you get alternating constipation or diarrhea. IBSD, which means IBS diarrhea, and IBSC, which means IBS constipation. So there is no functional issue in that case. So that is, it also comes down into this category. And depression, why does and how does depression cause functional constipation? Because the patient may develop stool withholding behavior, and stool withholding behavior results in progressive dehydration of the stool that is stored in the vault, rectal vaults, resulting in stool impaction, stool hardening, and then constipation. Medications that reduce the GI motility, such as opioids, they combine at the Mu receptor in the GI lining that results in reduced mobility. And one of the common side effects of opioids is constipation. So, opioids, anticholinergics. Anticholinergics antagonize the muscarinic receptors present in the GI lining, resulting in reduced GI motility. Calcium channel blockers, they relax the smooth muscles in the GI tract, thus contributing to slowed peristalsis and GI motility, causing constipation. Hypothyroidism, also causes constipation because it results in overall reduction of the body processes, including bradycardia, low basal metabolic rate, and low GI motility that causes constipation. Hypercalcemia also causes constipation. Diabetes mellitus, it causes long-term or long-standing diabetes mellitus causes gastroparesis or reduced GI motility, resulting in constipation. Hypercalcemia is also a reason as it interferes with the GI motility and progressive contraction relaxation, that is peristalsis of the GI tract. So hypercalcemia disturbs the smooth muscle activity, resulting in constipation. Obstruction, you can get colon cancer. Once the stool is obstructed, it progressively hardens and causes constipation. So this is a reason. Surgical stricture, yeah, it's the same way. It causes obstruction, and then the stool progressively becomes hardens, and that results in constipation. Neurological, anything that causes impaired activity of the GI smooth muscles and disturbs peristalsis is gonna result in this, such as spinal cord injury, multiple sclerosis, Parkinson's disease. All of these result in inadequate GI motility, resulting in constipation. So, one of the main points here is recent onset constipation. The one thing that you need to keep in mind is that acute onset constipation without prior history of constipation is always an alarm signal. Recent onset constipation may indicate an underlying medical condition. In patients with Down syndrome who are at risk for endocrine abnormalities, evaluation of secondary causes should be done. For example, hypothyroidism, diabetes mellitus, hypercalcemia. So yeah, in a patient with Down syndrome who presents with constipation, you also need to rule out other things that are associated with Down syndrome that also contribute to constipation, such as Down syndrome is associated with diabetes, hypothyroidism, and hypercalcemia, and all these three are the cause of constipation, so you need to rule them out. before resorting or before checking out any organic cause. So, patient with Down syndrome who has constipation, you need to rule out hypercalcemia, diabetes, and hypothyroidism. So, we're going to discuss the pathological and functional constipation in pediatric population.
So the first question is, why is it important to identify the cause behind pediatric constipation? So when it comes to adults, the constipation, if it occurs after adulthood, we are most certainly sure that the reason behind the constipation is not a structural cause. And even if there is a structural cause, the history gives us a great idea about it. Like, for example, if an adult of 30 years old gets constipation, we are gonna identify his dietary intake of fiber, his activity level, and that is how we're gonna make a diagnosis of the reason behind it. And if the onset of constipation is acute in nature, we're also gonna perform physical examination, and we're gonna perform an abdominal x-ray to see whether the cause is either intussusception or sigmoid volvulus or cecal volvulus. So the differentials are really laid out, and we know that there is no congenital structural reason behind it. Whereas when it comes to pediatric population, the reason can be functional and pathological. What do we mean by pathological reasons? Like Hirschsprung disease, the child may not be born with adequate neural component in the descending colon, resulting in uh, improper motility that is causing constipation. The child may have some neurological disorder of the spinal cord where the innervation to the GI tract is not appropriate as it happens in spina bifida. So these are also one of these reasons. The child may have for example, cystic fibrosis, that is also a congenital cause resulting in thickening and hardening of the stool. That is one of the reasons that the child may also be getting. So the differentials for a child are different from those of an adult. So we also, whenever a pediatric population presents with constipation, we need to rule out the pathological reasons that are specific to children. So that is the point of this entire discussion, that when it comes to a child and constipation, we need to rule out the congenital reasons that might also be contributing towards the constipation. So let's just start with the pathological. So delayed passage of meconium, what does this suggest? This suggests either the child has incomplete development of the GI tract, like what happens in Hirschsprung disease, or intestinal atresia, where the intestine ends in a blind loop. That can also be a reason, because meconium is passed in the first days of life. So if that is not passing, that can be a reason that the GI tract is either not innervated properly, or it is ending in a blind loop. Another reason can be the child may have his cystic fibrosis that is causing thickening and hardening of the stool. That is why the child is not being able to pass the meconium. Whereas the signs and symptoms of functional constipation that point towards a functional constipation are different. Like if a child is 9 to 10 months old and then starts to develop constipation, we can presume that solid food introduction might be a reason, since the GI tract is not used to handling solid foods, and if the fiber intake is less, then it can result in constipation. Toilet training. So when a child initially starts to toilet train, they start to stop their stool. That is termed as stool withholding behavior. That can also lead to, since the stool is stored in the rectal vault for a long period of time, it hardens and causes constipation. School entry. This is also one of the reasons why, because when the environment of the child is changed, the stool withholding behavior sometimes gets worse. Sometimes if a child wants to use the restroom and he's in school, he won't be using the restroom, instead trying to withhold the stool, resulting in constipation. So a child that presents with constipation in the first few months of life, like the first few days or the first month or the second month, that points towards a pathological reason. Whereas a child who presents it later in life, it most probably is a functional reason. So what are the symptoms of pathological constipation, you're going to get alarm signals like poor weight gain. Whereas when it comes to functional, there are not going to be these alarm signals like poor weight gain, narrow ribbon like stools. What is meant by a narrow ribbon like stool? This indicates that the passage of the GI tract has been narrowed down. That is why the caliber of the stool is reduced. Blood is never a functional indicator of constipation. Blood is always going to be pathological. Bilious vomiting or fever. Bilious vomiting suggests that the food is not moving into the small intestine. It can be a reason. For intestinal atresia, or it can be also be pyloric stenosis, bilious vomiting. So what are the features that you are gonna see? And the other one is fecal soiling in cop in encopresis. What is this? Stool withholding behavior results in obstruction of the rectal vault, and the proximal liquidy stool then passes and presents as fecal incontinence. So this is termed as when the parents complain that the child, whenever they removes his clothes, they see liquid fecal stains on the clothes, so they consider it as fecal incontinence. But on the flip side, it's basically fecal impaction resulting in fecal incontinence. Painful, infrequent, large caliber or pellet like stools. So painful, infrequent, it means that they come after a very long time. That indicates that the stool has been stored for a long time. Large caliber, which is a normal finding when the stool is being stored for a long amount of time, so the caliber increases of the stool. Presence of absence of pathological features. Pathological features are weight gain problems, blood in the stool, or weird shape of the narrow and weird shape of the stool. So on the physical examination, I'll explain it really easily. Displaced anus. What does displaced anus indicate? It indicates that the problem might be with the child may have a problem of spina bifida. Increase rectal tone. What is, in which case is this seen? This is seen in Hirschsprung disease. Why? So, in order to explain the increased rectal tone, what happens in Hirschsprung disease is that there is inadequate innervation of the myenteric plexus in the submucosal area in the descending colon. So, what happens is that due to improper innervation and development of the nervous system, there is impaired relaxation. So that is what you guys need to remember in mind, that in Hirschsprung disease there is inadequate relaxation, there is inability to relax the descending colon. So what part of the colon expands? The unaffected part. So this is also asked in a question, that in Hirschsprung disease they're going to show you an x-ray and you're going to be able to visualize the dilated colon, and they're going to ask what is in which part of they're going to label the parts. The dilated is going to be labeled A and the non-dilated would be labeled B and all that other stuff, and they're going to ask which part of the colon is diseased, and the part of the colon that is not dilated and that is present distal to the dilation is the one that is diseased and is not being able to be relaxed and is excessively constricted. So this is the reason that the distal part of the colon, the rectum and the anal sphincter is contracted. So you're gonna, on digital rectal exam, you're gonna notice increased rectal tone despite the fact that the patient may have stool in the proximal part of the colon. Or sacral anomalies. What do sacral anomalies indicate? Sacral anomalies, like for example, hair tuft is seen in spina bifida, so they may be an indication of improper neurological development in the lower spinal cord, and this is the part of the spinal cord that innervates the GI system. So abnormal lower extremity neurological findings. For example, if a child has weakness in the lower extremities, you can assume, and you can safely assume that the child has problems in the lower spinal cord region, and that problems may also be affecting the lower gastrointestinal tract, leading to pathological constipation. So all these symptoms like a displaced anus,
it indicates towards spina bifida, rectal tone indicates toward Hirschsprung disease, sacral anomalies indicate towards spinal dysraphism or spina bifida. That can also cause improper neurological innervation of the GI tract, abnormal lower extremity weakness if it is observed, that can also be included, severe abdominal distension, that can also severe one can also indicate that there is pathological constipation. So this is how the examination shows. Whereas when it comes to functional, you're not gonna be having any severe or red signals like absence of any pathological. The patient may have anal fissure. Why? Because constipation and large caliber stools can cause anal fissure. So you're gonna most probably have fresh rectal bleed, not occult bleeding or not stool mixed with blood, just a stool coated with blood, and that would too be fresh blood, mild abdominal distension, nothing wary of that case. Workup. So what is gonna be the workup for pathological reasons? When it comes to it's gonna be really easy. We're gonna discuss disease by disease. So the urgent one would be Hirschsprung disease, cystic fibrosis. So if it's Hirschsprung disease, you're gonna see do a barium. So when it comes to Hirschsprung disease, you're gonna do a barium enema in which you basically do a contrast-induced contrast material is inserted through an enema, and then that is visualized, which shows distally, it shows a contracted colon and increased tone in the rectal vault, and proximally it shows a dilated part of the colon. I'll also give you a diagram to see cystic fibrosis. You're gonna, if you suspect cystic fibrosis, how can you suspect cystic fibrosis? Because cystic fibrosis causes delayed passage of meconium, and that can be due to thickening and hardening of the stool, so the meconium is not being able to pass. So delayed passage of meconium can happen in Hirschsprung disease because there is no adequate relaxation. So if you suspect Hirschsprung disease, additionally, since there's delayed passage of meconium and you can see that the rectal tone is increased, so you do a barium enema and visualize it. If it's just no other sign, just delayed passage of meconium, and you suspect cystic fibrosis, you're gonna do a sweat chloride test. If you suspect spinal dysraphism, and why would you do that suspect? If you see a hair tuft on the lower spinal cords, then you're gonna order a MRI of the lower spinal cord. So depending on what you suspect, you're gonna order the investigation. If you suspect celiac disease, you're gonna order the biopsy of the proximal jejunum. If you suspect hypothyroidism as the reason, then you're gonna order a TSH. T3 and T4. So basically, all the diseases that are in your differentials, you're going to order the following test based on those. So this is a really high yield finding of Hirschsprung disease. So as you can see, the distal part of the colon, the rectal vault has been constricted, whereas the proximal part of the descending colon is really dilated. So this is the disease part where my cursor is pointing, and this is the non-disease part which has been dilated. So in Hirschsprung disease, this is the reason the inadequate relaxation leads to delayed passage of the meconium. And whereas when it comes to cystic fibrosis, this is not the reason. The reason is the thickening and the hardening of the stool, since the secretions get really thick in case of cystic fibrosis. So depending on what you suspect, you're going to order the respective test. For Hirschsprung disease, you do the barium enema. For cystic fibrosis, you do the sweat chloride test. I'll also make up some scenarios for you in order to make it more easier for you to understand what I mean by all this. I'm gonna discuss the scenarios ahead as well. So when it comes to the functional causes, you're just gonna alter the diet, add the fiber, add the laxative, make sure the stool is soft in consistency, the patient, so the child does not get any more anal fissures. And that is if the child is new and going to the school, you toilet train the child, ask the child to not withhold the stool. So these are just functional and a little bit of other interventions like diet and laxative use. So it's not that much of a big deal when it comes to functional constipation once you identify the cause. So if you give this a read, it's gonna become more easier for you before we discuss some scenarios. Failure of symptom to improve after treatment for functional constipation, like I increase the fiber intake of the patient, give him laxatives, but still the constipation ain't getting better. And so that prompts us to further investigate a pathological cause. And one more thing, if the patient has Down syndrome and has failure to pass meconium, you should automatically go and do an investigation for Hirschsprung disease, because it is really common in patients with Down syndrome. So Down syndrome plus failure to pass delayed passage of meconium, you do a barium enema, and strongly associate history of delayed, which is strongly associated Hirschsprung disease. And so delayed passage of meconium, two differentials should be in your mind: Hirschsprung disease and cystic fibrosis. So features seen in both functional and pathological constipation include, obviously there is constipation going on, it can cause anal fissures, so painful defecation leading to anal fissures and lateral bleeding. This is common in both. Mild abdominal distension would be seen in functional, and left lower quadrant firmness or palpable stool in the rectal vault may be present due to stool retention. So obviously if you palpate the left iliac fossa, you're gonna get a palpable stool or hard mass would be observed. In contrast, severe abdominal distension, ribbon caliber stools, rectal bleeding in absence of anal fissure or hemorrhoid. These are the alarm signals, alarm symptoms. So you need to be aware of these. Red flags suggestive of pathological lower extremity weakness. So we suspect neurological dysfunction, sacral anomalies. We suspect spina bifida and spinal dysraphism, history of poor growth. All these are in fact symptoms and signs of red signals or red alarm features of. So we're gonna move on to the examples of all the scenarios that you might encounter. As I told you guys, we're gonna discuss that, and that's gonna make everything that we just read really clear in how you're gonna deal it with these problems clinically. So example number one, a 3-day-old male baby passed meconium on the third day. So usually meconium should be passed on the first day of life as well. So this is considered as delayed passage of meconium. When the rectal tone is observed, the rectal tone is normal. Physical examination is also normal. Next best step. So what can you suspect in this case? Whenever there is delayed passage of meconium, two differentials should be in your mind: either cystic fibrosis or Hirschsprung disease. But in case of Hirschsprung disease, since there is abnormal contraction of the distal part of the descending colon and the rectal vault, so the rectal tone is usually increased, so we can rule it out since the normal rectal tone is present. So no Hirschsprung disease. The other differential left is cystic fibrosis, so the next best step would be performing a sweat chloride test. That is going to tell us whether the patient has cystic fibrosis. What happens in cystic fibrosis? There is thickening of the secretions, so the stool or the meconium becomes really thick and hard, so it is unable to be passed frequently and on time. So the next scenario would be a 4-day-old male baby hasn't passed meconium yet. Usually he should have passed meconium on the first day of life, so this is considered as delayed passage of meconium. On digital rectal examination, there's a sudden expulsion of gas. So this is termed as squirt sign. So what is a squirt sign? So since in Hirschsprung disease, the proximal part is contracted, including the rectal vault, so gas and stool backs up proximally, and distal part is unable to relax. That is the disease part, the distal part. So when you do a digital rectal exam and you probe your finger, and that results in opening or transient opening of the rectal vault, so all the proximally accumulated gas just suddenly gushes out from the anal sphincter. That is termed as a squirt sign. So this is a sign of Hirschsprung disease. Anus is midline. Next best step. So in this case, since there is a squirt sign, which means they could have also written rectal tone is increased, but they'll usually give you a squirt sign. So that indicates towards Hirschsprung disease. So next best step should be we will perform a barium enema. So this is how the questions are gonna ask you, and you see just changing a few things: normal rectal tone replaced with increased rectal tone, Hirschsprung disease.
normal rectal tone, you go towards cystic fibrosis. So the next question is going to be a 12-year-old, history of chronic constipation since birth, on and off chronic constipation. So this is a really weird one. Treatment with laxatives and dietary modification failed to resolve constipation. Anal examination shows anal fissures, next best step. So you're also going to be asked a question like this, and this question becomes really confusing since most of the people expect that Hirschsprung disease needs to be manifested early on in the first few days of life. So that is actually not true. Depending upon the severity of the Hirschsprung disease, depending upon how much part of the distal colon and rectal vault has not been properly innervated, symptoms can vary from severe symptoms that present at the time of birth to mild symptoms that present as chronic constipation. So the anal fissures in this case are due to chronic constipation. And if it was just an organic cause of constipation, the laxatives and dietary modification would have resolved the constipation. But in this case, they have not resolved the constipation. And the patient has a chronic constipation, history of chronic constipation since birth. It's not like the patient was fine for up till 3 to 4 or 5 years of age and then developed constipation. He has been having constipation for a long time. So in this case, you suspect Hirschsprung disease, that is partial Hirschsprung disease, that is not causing any acute problems, just a chronic constipation that fails to resolve with laxatives and dietary modification. So this scenario is a really important one. So, mild Hirschsprung disease can lead to chronic constipation. That is the main takeaway point, and that would not resolve by the use of laxatives and dietary modification like increased fiber intake, etc. So, in this case, what is the next best step? You're gonna do a barium enema in order to visualize the contracted part of the descending colon and the rectal vault. And after that you're gonna do the confirmation. The next best step is barium enema, and if someone asks you what is the next best step to confirm the diagnosis, that is gonna be a biopsy, full thickness biopsy, that is termed as a punch biopsy of the affected part. Why not a mucosal biopsy? If they tell you a mucosal biopsy, that is not the answer. The answer is gonna be punch biopsy. Punch biopsy samples the entirety of the diseased part so that you can visualize the absence of the myenteric plexus. So next best step, barium enema. Next best step to confirm the diagnosis, it's gonna be a punch biopsy of the distal descending colon or the rectal vault. 4-day-old passed meconium on the third day of life. So this is considered as delayed passage of meconium, has Down syndrome. Next best step. Obviously, he has Down syndrome. Down syndrome has a high association with Hirschsprung disease. So you're gonna do barium enema. So this is how, just changing a few things, the scenario when it comes, it's going to be really long in length, and that becomes really overwhelming. But in the end, it's just 2 to 3 points that you need to make a diagnosis and reach your answer. So the answer would be, we suspect barium, we suspect Hirschsprung disease since the patient has Down syndrome and delayed passage of meconium. So we're going to do a barium enema in this case. So another question that you might ask is also, why have we not considered duodenal atresia in this case, since Down syndrome also has an association with duodenal atresia. So since the patient did pass meconium on the third day of life, we cannot say it's duodenal atresia. That's why we resort to the diagnosis of Hirschsprung disease. But on the other hand, if they say 4-year-old has not passed meconium yet, then we could have kept both the Hirschsprung disease and the duodenal atresia in our differentials. So another question would be, a 4-year-old recently began going to school, complains of painful defecation, anal fissures seen on the examination. So anal fissures have occurred due to constipation, no prior history of constipation. That is the main point. The patient was really fine since he started going to school. Parents tell that the stools are hard to pass and large caliber. Next best step. So this sounds like a functional constipation since the patient was fine initially, but when he started going to the school, he developed constipation, and most likely this happens due to stool withholding behavior when a child changes his environment. So children are really shy in using different bathrooms in the school, they are used to and more comfortable with the toilet training they have at the home. So when the bathroom or the environment changes, they prefer to hold the stool instead of passing it. That results in constipation. So the next best step would be to toilet training or add laxatives or dietary modification. So most probably they're gonna give you toilet training or behavioral modification. That is gonna be the answer in this case. Once you understand the reason, you can pick the answer really well. So in this case, what is happening? It's basically a form of functional constipation because the child has changed his environment. So you're gonna do a behavioral modification in this case. 3-day-old male baby passed meconium on third day of life. Normal rectal tone, so we rule out Hirschsprung disease. Physical examination shows lower extremity weakness. So now we resort to spinal cord issues that might be leading to delayed passage of meconium due to improper GI motility. Next best step would be, since there is lower extremity weakness, you're going to order a MRI of the spinal cord to visualize any defects in the lower spinal cord that may be leading to delayed passage of meconium due to improper innervation and lower extremity weakness. So you're going to order a MRI of the spine. 3-day-old male baby passed meconium on the third day of life. Normal rectal tone, no Hirschsprung disease. We rule out the Hirschsprung disease because the rectal tone is normal. Physical examination shows a displaced anus. Next best step. So what does a displaced anus represent? The displaced anus represents anorectal anomalies. Either the rectum ends in a blind pouch, or it is not connected with the anus, and other malformations as well. So this displaced anus is basically associated with, it has a vectoral association. This is a mnemonic for a certain syndrome of diseases which are termed as vectoral. Uh, Basically, C stands for cardiac anomalies, T and E stands for tracheoesophageal fistula, R stands for renal anomalies. So, what is the next best step in this case? They'll give you a lot of things, and you can pick either renal ultrasound, you can pick the test we perform for tracheoesophageal fistula, or you can perform a echocardiogram for the heart. So basically, it has a vectoral association. That is why you can pick any diagnostic test that falls under this category of vectoral. Renal anomalies, tracheoesophageal fistula, cardiac anomalies, echocardiogram for this. For renal anomalies, you do a renal ultrasound. For tracheoesophageal fistula, obviously, it's really apparent on the physical examination, since the baby cannot drink any fluid. He starts choking since the trachea, or since the esophagus ends in a blind pouch and connects with the trachea. So you're gonna have asphyxia, you're gonna have aspiration, and the baby is gonna cough out everything that he drinks. So no diagnostic test really required for this, because it's gonna be apparent on physical examination. And if you suspect tracheoesophageal fistula, it is confirmed by passing a nasogastric tube, and the nasogastric tube would be unable to be passed. That is how you confirm tracheoesophageal fistula. But if you get a displaced anal, just remember vectoral association and pick any of the diagnostic modalities that come forward. So let's just review a table here as well. Infant constipation. We're gonna see the pathological causes. Down syndrome causes Hirschsprung, as I told you guys. Displaced anus, anorectal anomalies, stuffed at the gluteal cleft. It represents spina bifida, or anomalies of the spinal cord that happen in spina bifida. So if you see a tuft and delayed passage of meconium, you are gonna order a spinal MRI. Delayed passage of meconium is a hallmark. Poor growth, severe abdominal distension, Hirschsprung disease, you do a barium enema, cystic fibrosis, sweat chloride test, spinal dysraphism, which means lower extremity weakness, or a tuft on the lower spinal cord, you do a MRI. So if it's functional, you just do a behavioral modification, you add laxatives, and you add fiber to the diet. So anal fissures can be present in both these cases. So anal fissures are not specific to either functional or pathological. Just remember these high yield cases. That's how they're gonna ask you. Esophageal